Welcome back. We have a little bit of a switch for the afternoon lectures. So we are going to start with Corey and Mark giving their presentation, and then Dr. Affel will give his presentation at the end. So welcome back, Corey and Mark.
Welcome. Thanks for having us. And we're back. For those of you that can't see us at home, Dr. Blumenstein, Dr. Lappin, Corey, take us through a deep dive into eyelid health and ocular surface wellness.
Yeah, so as people start trickling back in here, basically this is just going to kind of bring us full circle today. We've alluded to a lot of things. We've showed a lot of nice lash pictures, which we're going to actually describe a little bit more here. And I really liked how you and Selena were talking about this morning. When people talk about ocular surface disease, I feel like we use the term, but not many people actually think about what that means. What is the ocular surface? I say you have the glamour parts, you have the conj and the cornea, everyone looks at that, but really it's starting with the lids and lashes, it's the tear film, it's the glands, it's all of that in concert. And really, you talked about it earlier today, so often we're treating with an and the reason for that is because if one component of that ocular surface is out of whack, the entire thing will fall apart for this. So we're really going to kind of start with here the lids and the lashes, because when I'm looking at the ocular surface, that's where I start. I like to work outside in, because it's so easy, again, like I said, to start focusing on the eye proper that you just completely ignore the external elements of things. And then here are our disclosures. Again, we've mitigated things. Mark made sure we're very well mitigated today.
We're mitigating as much as we possibly can.
So this is kind of what I was talking about here. So the function of the lashes, it's more than just, we just don't have them just because we want to look pretty here. They're mainly for blinking and kind of shielding debris. And they're also critical, and I know you guys had talked about this earlier, to actually like tear secretion. That was a major element of everything here. And then we're just really going to kind of take a jaunt, if you will, through a potpourri of different diseases of the eyelids and how we manage them. So what do you see when you see here, Mark, with this picture?
The first thing I see is some neovascularization. I see some oily tears. I see saponification. I also, it looks like that sheen down on the lid looks like it's some biofilm. Maybe even I'm seeing some collarettes. What I'm seeing here is a disaster.
Exactly. And
has anybody else seen a disaster? Just looking at this, thank you for paying attention.
Yeah.
Stuff.
And so often though, what's the thing for most people, if you're not looking at the lids, how much of this would you miss?
What's funny is I didn't even see if you have everything listed on the left-hand side.
See,
I was focused on the picture, damn it.
Well, and that's because that's really what it is. It's the classic. There's a reason why we all say, pictures are worth 1,000 words here. Yeah. And it's because you see all this going on here. So really, if you think you go behind the slit lamp and you look at this, you're seeing multiple diseases at once here.
Yeah.
And that's saponification. You know kind of how you're talking about symptoms. If you have saponification, you're already at a really bad level of ocular surface disease. Your lids are in bad shape here, because basically what this means is you have a bacterial overgrowth and it's producing these enzymes that literally break down lipids. Saponification basically means soap making, and then you blink and you kind of froth it up, and what do you know, you got suds on the lids, and that is not a good thing.
I love having pictures like that, the one you have here, because I think one of the easiest things to do is to get patients to see what you're seeing. So by taking a picture of that and making it relatable. So, when I see saponification, it's like exactly what you said. You know what? You have an overgrowth of bacteria. It's soap in your eye, which also what really, really frustrates me about clinicians is that we always try to look for the easy button. And I get it. We want it to be simple. And so things like, hey, moist or like or a compress, like, sock with rice in it, I don't think that's easy because patients will complain about what kind of rice. Basmati,
what kind of sock? Is it a tube sock? Is it like ankle sock?
100%. Does it have to be clean?
Yeah.
All that. Okay, have every one of those questions. But the bigger thing is that people who use baby shampoo, and I've never understood that. You're dealing with an eye that is producing soap. And so you're going to use soap to do what to the soap? It's like, we're not helping our patients by doing things that are simple.
Well, you know how the whole slogan for baby shampoo is no tears?
Yeah.
What it really is, it's no good tears.
Yes.
That's actually what
it
stands for that. I mean, I've actually seen, and I have a slide for this later where I kind of talk about why you want to avoid that. You've probably seen it. I have what I call baby shampoo blepharitis. And it's where patients have used it so many times, they've stripped all the natural oil off of the lid skin itself. and they get that dry, flaky skin and it's completely irritated.
Yep.
And I ask the patient, I'm like, well, what do you do about that irritation? Well, I just use more baby shampoo.
Yeah.
So it's just at this point, we are way past that. We're going to talk. We have way better ways to manage it. But like you said, we don't like seeing bubbles on this. And when you use baby shampoo, that's basically what you're doing.
So Corey, I know your next slide is going to be.
Yeah.
I have a whole different belief as to where I think that saponification is coming from.
Oh, really?
Hit your next slide. Okay, this.
Yeah.
So for those of you who can't see, well, you all can, everybody can see the slides, right? I don't know if they, right? I thought they're just.
I would hope so. I would
Yeah,
hope so. Or,
yeah.
or we're speaking into the void, which is also fine. We have nice enough voices, I feel like.
So, I mean, you have a picture up here of just an absolutely ridiculous looking amount of collarettes. And if you can't tell, that's Dr. Lappin's because it says it down here in the corner.
Yeah, yeah.
So Corey, your lids are disgusting, okay? Hopefully you're doing something to treat that. You know, you mentioned here about this being, you know, Demodex,
Yeah.
Demodex blepharitis, 100% pathognomonic for the fact that collarette means that there's an overproduction of those mites in there. But do we get in any deeper dive about what specifically about the mites?
Oh yeah. This is just the intro right here to everything we're about to do.
It's a good thing I went through the slides. I told you, super prepared. Did you like that?
Yeah.
Okay, so I'm going to come back to my saponification discussion because I think that it's because of the Demodex.
Yeah, and I already know that's where we're this. I'm like, I already know where Mark's going for this because we're going to find that blepharitis isn't kind of like we talked about evaporative and aqueous deficient dry, how they're really not these neat separate buckets.
Right.
Really, we're going to kind of find out where we're traditionally taught about bacterial and Demodex blepharitis. They're probably not as discrete as what we previously thought.
Not at all.
So first of all, so what's going on with these guys? What exactly are the Demodex mites then, Mark? What are they?
They're parasites, people, and I get it. You know, one of the things that I like to tell patients is that, you know, we're the host to a lot of good stuff. Bacteria, viruses, parasites. Who doesn't want to be with me, right? And I'm not just, you know, I mean, that's just reality. But they basically eat dead skin cells. They kind of thrive off of lipids. So they do serve a small purpose for us. But when they overproduce in the follicle, then they leave behind all the digestive disease. But if you think about it, what they're doing is they're basically eating themselves into oblivion. And the interesting thing about it is you can see here, their life cycle is basically what, about 3 weeks, give or take. There's two different kinds. The folliculum is the smaller, or is the larger ones, excuse me, and then the smaller ones is the brevis, which is believed to be maybe in sebaceous glands, meibomian glands. But now take this into fact. They're 8-legged little creatures.
They're arachnids, by the way. So that's the fun fact I'm going to add. This is the only time I get to use my zoology degree nowadays is when talking about this. So these guys are arachnids. So they're cousins with spiders and ticks. So all the fun family reunions, by the way.
Oh, good. So you tell me, do they have an anal cavity?
I'm so glad you asked because that's exactly what I was going with. So on my news, you know, my very curated algorithm-driven news on my phone, I got on my top thing about a year ago, mites might have an anus, as the skin mites might have an anus. And I'm like, well, do tell me more. I do like these mites. So tell me more about this anus. Let me take a look and take a gander if I think this is. And lo and behold, I looked at the paper and I saw a mite anus. But the question is now, is it functional? That's the question. So this is where, again, I get to dive into like the evolutionary history of these. So why do we have these in the first place? It's thought that early on in our ancestors that they outcompeted worse things, that there were other mite species, other parasites that were worse. So we're like, well, you know, we'll take an enemy that's a little bit less detrimental. But as time's gone on, they no longer really serve that purpose. And it's even thought that as they consider it to be parasitic, that they're losing function, that this gut that they still have might not be functional. Here's my takeaway. Whether it's vomit or feces, you don't want it on your lids.
Right.
So that's the big thing there. So either way, these guys are there. They're either thrown up or they're pooping all over the place. And that's not good. So again, no one wants that on their lids. And especially when we go back and we look at those nice juicy collarettes, that is feces, excreted material, eggs. These guys aren't just a sign. These themselves are pro-inflammatory. So not only do you want to get rid of the mites, you really want to get rid of these collarettes.
But they also carry bacteria.
Yes.
And so the bacteria that's on the exoskeleton is more common to what we're used to, staph, strep. But internally, and you correct me if I'm wrong, it's Bacillus Osterium or Osteria?
Olinarius.
Oh, near. See,
Yeah.
he's a zoology major. So yeah, you say zoology?
Yeah.
Nice. So the bacillus, to me, I think that's what's causing those lipases. I think that might be what's kind of more indicative of the saponification.
It really might be, because for so often, and one of the things when we talk about that, there's a lot of good treatments we have, and they could potentially get the saponification under control, but it would keep coming back
Yeah.
when you stop doing this. So really, that's kind of what they're thinking at this point. Is it might be a lot of the bacterial blepharitis. It's purely that the mites are just acting as a vector.
Yeah.
Instead of being necessarily these two separate things. But anyway, you see this saponification collarettes, they're signs of distress. Something's wrong, and you're going to want to clean that up. And then here we kind of talked about that. So 5 years ago, first of all, were you looking for collarettes?
No, I'm going to be honest with you. No,
Yeah.
I'm one of those people who subscribe to the belief that it's like, I ask patients how they're doing. They're like, I'm doing great. I see the nastiness on their lids, called them Miss Jackson because they're nasty, and they didn't have symptoms associated with it, or at least my belief they didn't have symptoms. The challenge I also had too was the current treatments we were doing 5 years ago. It didn't really change anything for me.
Yeah, exactly.
So I really wasn't going out of my way.
And at the time, if you did look, did you care if you called it collarette, scurf, debris?
Scurf, no.
Yeah, and did you really even know a difference at the time? We're like, well, that was just all the terms we're taught. I a lot of times would be like, oh, it's lid debris.
Right.
Like, just keep it general. We knew that, but it's because, again, we didn't really have a point to look for it. So then here, how do you look for it now?
Pretty much, it's one of the hardest. Honestly, people, we should have a lab so that we could actually go through how to diagnose this.
I think we could do it right now. I think we have enough time.
Yeah, between this and NK, I mean, these are the two hardest things for us to be able to determine. So this afternoon is going to be really challenging. You basically put them behind the slit lamp and ask them to look down. Boom, nailed it. Thank you for coming to my talk. Appreciate everybody.
Yeah, I think we can wrap it up right now. I think you're gonna make your flight, no problem. We just took care of all of it.
Yeah, we moved so I can make my flight, but you know what? We're gonna do this. Okay. I mean, do you subscribe to the LLPP method of evaluation?
Is
that too easy, too simplistic?
Sometimes for me, but it's
not for me. I like easy. This was something that was developed, I think, by Priya Gupta and Chris Starr, part of ASCRS. They're ophthalmologists. Don't hold that against them. And literally what they did is they said, LLPP, look. First thing we do is we walk and we look. And so I kind of made that LLD, LLP. So look down, lift and pull, and then push. So everything when you're behind the slit lamp, you're looking for rosacea, you're looking for, any abnormalities, tylosis, you're looking for irregular lashes, all the things that Corey had on that first picture, okay, lesions. But then the LD, have them look down, the LP, lift and pull underneath the lid, looking for SLK, looking for the meibomian glands, and then P, the pushing on the meibomian glands. It's just a simple way to kind of like move through the eye.
And I do really like that from, if you're, for everyone, really, that's going to be beneficial.
Yeah.
I'd agree. Because honestly, part of it for me with that, I always say with looking down, I think back to my residency, and the reason why I think about this is that's when I was taught to really, evaluate things at a greater detail. And what I always like to see, so how many of us have been in our clinic, we're behind the slit lamp and we're looking at the anterior segment. So we're spending, maybe 30 to 60 seconds, which is a long period of time, right?
Yeah.
Looking at the eye. And then the patient asks, so Dr. Blumenstein, what color are my eyes?
Yeah.
And you're like, I have no freaking idea what color your eyes are.
Yeah.
I have no idea. They ask us, you're like, I have no idea what it. I'm like, so the correct answer is, well, what color do you think your eyes are? What have people always told you? That's how you get out of it. And you're like, that's exactly. I'm like, that's what I thought too. But the difference with there is because it highlights what I always was told my residency, you looked, but you didn't see.
Yeah.
So you can look at the surface, but what's happening is that we're only trained to pick up on things that we deem important. So we've probably been seeing these collarettes, but we are so good at like catching what we caught. So we're like looking for SBK, we're looking for certain signs. So we have to retrain ourselves to look and see certain things. So now once I started looking for collarettes specifically, I saw them all the time.
Always.
So
I actually was part of the Atlas study, I think, where we went in. Were you also?
So for me, it was actually when I was writing a review paper on basically this, and I saw that they were estimating, they're like, oh, it's maybe like about 60% of patients like have this. And I'm like, okay, well, let me see. And I'm like, it's probably at least 60.
I literally went in, we took 100 patients, And I walked in, and it didn't matter why they were there. Contact lens recheck. I know you're thinking, why are they here to see a contact lens recheck with me? I don't either. Refractive surgery procedure, full exam. All I did was said, can you just look down? And I looked for collarettes. And one collarette is too many, as far as I'm concerned, from my experience over the last year of managing this disease state. And our practice was like 70%. Easily.
Oh,
easy.
Yeah.
7 out of 10 patients had a collarette. But to your point of just like looking through it, a perfect example to me is the way most optometrists manage diabetics. Is that the notion is, we got to get to the retina because that's Spanish for retina. So we need to get in there and look for retinopathy. When the vast majority of those patients have dry eye, have ocular surface disease. And it's like you're going to miss the forest through the trees if you're not pulling back and looking at the front of the eye.
And I love that too, because why do we miss all of our diabetic patients? Because most of them are asymptomatic from dry eye, because what John's going to talk to us about, most of them are neurotrophic, and they're like, well, I'm not going to look at that. And like, you literally look through the window at SPK and you're like, geez, I can't get a good view of the retina here. I'm like, gosh, get this out of here.
I'm going to refer you out to retina because I can't see.
Yeah. And let's be honest, all of us have to take care of it because we know retina's not going to look at the cornea. So, and then this is another one that's super easy, but honestly, sometimes I'm surprised how some practitioners will talk to me and they'll get a little bit tripped up because they're like, my patient's describing itching. How do I know if it's dry eye, or how do I know if it's from allergies? And for me, I'm like, there's a lot of simple ways to do it. One is you can look through a papillary reaction. That's an easy one when it's really bad. But even then, one of my favorite questions to ask is, well, how do your eyes feel when you rub them? To which you're like, they're not supposed to rub their eyes. Guess what, people? They're rubbing their eyes. That's what they're going to do. And I ask them, like, does it feel better or worse? If they mention that their eyes feel better after rubbing it, it's probably dry eye because they're actually mechanically getting reflex tearing. Whereas if they rub and it gets worse, they're actually granulating more histamine from that mechanical rubbing and it gets worse. Or the easiest thing is just keep a drop of like Pataday in your office, put it in. Does that feel better? Great. But what if they're not talking about itching of their eyes, but you don't ask? And they just say, my eyes itch, but they're actually talking about the lids.
Well, I asked them, where is the itch?
Yes.
I mean, is it right at the lid margin? Is it the whole eye? The other thing too that I find with allergy more so than maybe some other, blepharitis type, is that it's the bilarity of it is much more pronounced in allergy.
Oh, 100%. If I'm seeing, outside of like a contact dermatitis, if I'm seeing unilateral allergies, I'm like, that's just not how allergies work. So exactly, that's one of the easiest things for that. So even asymmetric, they tend to be pretty symmetrical too when it's allergies. So that's another easy thing. Really, it's something where I find that really by just looking at the eye, you're going to be able to discern that pretty easily. But I actually think the biggest takeaway is asking where the itching is. Because patients will say my eyes itch. They will never, in their mind, they say that. Lid itching and eye proper itching can actually mean very different things. And the patient can actually keep coming back to you for saying that their eyes are itching when they're talking about the lids.
You have the upper lid flip there, and I'm terrible at flipping the upper lid. I'll pull out lashes. I'll see somebody who comes in with beautiful like extensions. I don't know if you have extension, but your lashes are beautiful. And I'll be like, damn. And they're like, Mama, my lashes. And I'm like, okay. And so then sometimes I'll just pull it up and just pretend I looked. I know. I admitted it. You guys all do it too. Don't even lie. Don't even lie. If you're like, after a while, you just give up. Have you ever used the Myverter?
So yes.
Yeah. I love that device. I mean, I know I'm pimping hard on it, but it's a handheld, it's like a forceps that basically have these little polyethylene
grippers.
Yeah, little grippers. And it's weighted so you can grab the upper lid with one hand. You just grab onto it, squeeze it, flip it, and it's phenomenal. My staff uses it. So they'll say, oh, I think I saw a concretion. I'm like, oh, I saw a concretion. And sure enough, there was a concretion. So I'm like, why am I even here? Right? So I could take it out. But yeah, anyways.
And with that though, I will tell you for me that I am very big on averting the upper lid. It can be a pain, but especially with things like mybography. I know that's probably not what most people do, but my biggest thing is like, so do we just look at the left eye when doing an evaluation? How often do we only evaluate 50% of a structure? So I know it's a pain, I know it adds time, but I am very big on averting and evaluating that upper lid. So just my own little soapbox right there on that. And then MGD, we've talked about this a bunch today. Actually, the point I would probably want to make from this is the multifactorial nature. And this is like kind of dry eye in general, because we've talked a lot about inflammation and evaporative today. When it comes to this, I always like to think of primary and secondary inflammation. And the reason for that is because I'm with you today. I'm so glad you mentioned steroids, because I find two major problems that people have with steroids. Either they avoid them entirely or they over rely on them, but there is a place for them. Basically, one of the big questions, I'm sure you've gotten it when you've discussed like Myabos, Eyelid, they're like, which one do I use first? Which one is that? Is there inflammation? This gets a little kind of maybe academic with this, but I always think of inflammation being primary versus secondary. So secondary inflammation is downstream. You have something like basically mechanical obstruction of the meibomian glands, which causes dysfunction, which leads to inflammation. A steroid can be great in this patient to get them calmed down quickly, but that's not going to fix the underlying cause. Now, if a patient has Sjogren's syndrome and they're more inflammatory in general, you're going to want to do an anti-inflammatory at a root cause because you're actually cutting it off. But that just kind of, to me, I always like to think of it that way because it's a good framework with letting me know where does an inflammatory play in this. So to me, I don't know, do you think that's too complicated for that then, Mark?
No, I love it. I mean, I just think we have so many great tools in armamentarium, and I think sometimes people just gravitate towards one as opposed to thinking about outside the box is like, where is that going to benefit? Or better yet, how are these going to work together?
Yeah.
So,
and honestly, for the most part, from all the things we've talked about, MGD really, most of the time, I would say it's a downstream effect. Wouldn't you? I mean, you can get primary obstruction, but a lot of times I feel like that's a major contributor in general. Just ocular rosacea, Demodex that we've talked about. So many of these different things can really lead to this.
But you know, it's a simple, nothing simple that we do. But when I see MGD like this, I will debride those lids even just as part of just a regular routine exam. Because, you know, you talk to patients about doing moist heat, you talk to them maybe about doing a new lids at home, you talk to them about doing anything, you know, interventional care in the office. But if you're not removing the keratin, then a lot of those things become even more challenging. So even if you, I mean, you know, the one thing that I encourage anybody who's thinking, I don't know, manual expression or, you know, doing these things, practice. Yeah. Just every new patient that comes into your practice, if you were just going to say, you know what, I'm going to do something that I suck at, like scleral depression, they have no idea. Hey, they don't know what's going on. You do it. And if it's terrible, then they'll say, what were you doing that for? And you'll tell them like, oh, no doctor's ever done that on me. And it's like, you mean no doctor's ever tried to do it on you, okay? I mean, I have patients, I'll do gonio, I do. And so I started doing debridement on every patient. And now it just becomes one where it's like, I'm out of there.
So again, when John talks about NK later, that's how I got good at testing sensitivity. Is everybody was getting sensitivity tested, normals, everything. That's how I actually calibrated my testing, is because what happens when you have those bilateral cases of NK and you don't really have an active comparator. So something like that, really to Mark's point, to really any skill you want to be good at, just practice.
Practice? Are we talking about practice? Practice? For those of you, thank you, appreciate it. Yeah.
And the big thing for me is anytime
it's a deep cut.
I see a capped gland, I'm like you. I always have to get rid of that.
Oh, you got to get rid of it.
You have to, because that gland is in actually a lot of danger if you don't get that on camera.
There is nothing more. Come on, Dr. Pimple Popper is not a phenomenon for any other reason except people like popping pimples. So you can see those in there. Go to town, people.
Yeah. So you see something like this, and it's very satisfying.
Yes, totally.
And this is one of the biggest things. And earlier, I feel like you really nailed this. And I talk ad nauseum about mechanical eyelid issues, specifically lid malposition, because it's way more than just lag ophthalmos. Oh, your eyelids aren't closing. And you hit it. I liked because that overbite, that's exactly how I describe it. So a poor lid seal and lag ophthalmos are fundamentally different things. They can lead to this same place here, but they are fundamentally different. Lag ophthalmos is the lids are not closing. You can get a poor lid seal where it looks like the lids are closed, but they're not making that basically airtight seal that you want. And they're gonna, especially, I ask people how they sleep all the time. I'm like, are you a side sleeper, face sleeper? Because if you have that poor seal, or if you have floppy eyelids, you put that face into the pillow and you're just really cranking in there, you're gonna get friction, you're going to get that exposure. And I'll tell you, the amount of patients where that's actually their biggest problem is eyelid position. I've actually helped so many patients like, oh my gosh, I just started using like the sleep tight or the sleep goggles, which I'll talk about. And they're like, I feel great now. And
so let's digress for a second. Okay. What's the symptomatology of patients that have like floppy eyelid syndrome? Because it's interesting to me is I know we talk about it a lot, or you hear it, floppy eyelid, and I'm not going to ask you guys because you're in a food coma right now, and also the alcoholic beverages you guys had. But how many of you guys actually evaluate for floppy eyelid syndrome? And like, what would be the trigger to do that? Because that lift and pull that I mentioned, you're kind of really looking for the laxity of the lid to see if there's floppy eyelid. So what symptoms do you?
So that's the biggest
that,
thing. So I am obviously, I lift up on all of them, basically take a look. And once I feel it, pull over their forehead, then I know that it's there.
Yeah.
First thing I normally ask is the easiest one for all nocturnal issues. How do your eyes feel when you first wake up in the morning? Right. It's the easiest, highest yield question. But then a lot of the times I just also talk about redness, because they normally have some of the worst cases of erythema just because they're getting that mechanical rubbing. But I simply ask them, like, first of all, how do you feel in the morning? But then when I'm thinking floppy eyelid, then I ask about snoring. That's my second two after that, because then, Selena and I were mentioning we're already looking for sleep apnea at that point.
Excellent. I missed your talk. Sorry, I was outside. Sorry, I missed that.
Yeah, but that's, you ask for a lot of the same thing? Are you looking down that sleep apnea rabbit hole for this? Because it's, we were saying too, and the big thing I always tell people about that is that a blepharoplasty will not fix that.
Nope.
That's one of the biggest things, is so often like, oh, they're floppy, let's get them. I'm like, okay, I'll see you in 6 months when you need another blepharoplasty, because we did not fix the underlying issue for this. So how do you feel about styes and the term stye?
Why are you saying that to me? Does somebody like trigger? That is a trigger to me. There's no such thing as a stye, people. And honestly, I used to have interns that came in to work with me, and they stopped coming because I felt my modus operandi was to break them down. Somebody else could build them up. So literally, if they didn't cry within the first week, it just wasn't worth my time. Okay. And so they would come to me and say, I have a stye. And I go, what's a stye? I go, find me the ICD-10 code for a stye. And if you do, then I will let you skate through the rest of this. If you don't, and you say it again, I will fail you on the spot. I know. And then they start crying. And then I feel like I made my day. I feel nothing about styes. I'm dead inside. But hordeolums and chalazions, I feel a lot about those.
I honestly think a lot of times we use that. I understand when the patient uses it. I think it's used clinically sometimes because we don't think too much about what delineates the two.
Yeah.
And again, making things simple is the way to do it. So basically here, a chalazion is going to be inflammatory in nature, a hordeolum is infectious in nature. That, at the end of the day, if you can keep that framework, it's going to be easier for you. Basically, the easiest ways to a chalazion is typically going to be a meibomian gland, where hordeolum can be a meibomian gland, or it's going to be, can be a lash follicle, it can be some of the other oil glands. But really, that's the difference, inflammatory versus infectious.
For me, the biggest thing, though, for us as clinicians is if you have somebody that has a recurrent hordeolum in almost the exact same spot consistently, then you need to start thinking sebaceous adenocarcinoma.
Yeah.
Okay, we under or misdiagnose that by upwards of 3 to 5 years. And part of the reason why is because they look just like this. You'll maybe start to see loss of lashes. You maybe start to see maybe a central kind of vascular area there, but they look like a hordeolum.
So, and that's one thing. I think this might be a bit more for us, just being in the desert environment. I see basal cells all the time.
Yeah.
I feel like for us, because of this is, it's important for all of us, but I just feel like being in Phoenix, like we really, at least we should be, everyone should be, but we really have to pay attention to those lid lesions. And what you just mentioned there, again, I like to keep everything very simple. If you are getting focal lash loss, focal bleeding, lid margin architecture changes, you should be thinking of something cancerous.
Yeah.
Because those are the hallmarks for this. Anytime I see not just this, but any lid lesion, those are exactly like, has it changed color? Have you had lash loss? Anything like that? Because I know right now I've been 100% sending out for basal cell, because if it looks like that and it looks abnormal, do your patient a favor. I always ask them, do you have any history of skin cancer? A lot of times they'll say yes. And you send them out, and it's really easy to chalk it up to something else like that. But I think that's an amazing point that you bring up. When you get those changes, you really need to be not missing something more serious.
Because a lot of these patients, they have rosacea. You see it, that look, when you first walk in, the red ruddiness to their cheeks. And you asked me, Corey, what was I doing 5 years ago? Well, right now, today, when I see that red ruddiness, my first thought is Demodex.
Yeah.
And if you look at this picture he's showing you, can anybody see the collarettes that are here in the upper lid on the left-hand side there? You see a little bit of loss of lashes. But this, to me, is a perfect example that my mindset now for people that have hordeolums is starting them on a treatment for their Demodex.
Yeah. because it makes sense. So one of the biggest things about this, I think for so often it was like anything, when there's not a treatment for things, we often just kind of ignore it and don't think much about it. But they actually think one of the biggest drivers of developing a chalazion or a hordeolum is, again, you have brevis, which likely is going to be in the sebaceous glands, specifically the meibomian glands, and they have a chitinous exoskeleton. That's a foreign body, and that over time leads to a hypersensitivity reaction, and you get a granuloma. So we're going back to the basic pathophysiology here, and that's what's happening here. And it's the same reason why these can be recurrent, because unless you're getting rid of the root cause, which is the mite, it's just you're treating what's downstream for that. So I'm the same way at this point. Once I hear recurrence of this,
Yep.
I'm going right to that.
I literally, I mean, I've had patients over the last year where as they got older, they started getting more recurrence, not in the same place, but just multiple
Yep.
or getting. And just this past week, I had a kid who came to see me whose whole lid, I mean, was just, you know, you will have those ones where they come in like 2 or 3 of them and it's swollen and it's hard for you to look at them, but you're supposed to. And I'm just like, can you please just look away? And I started him on some Demodex treatment because I know we're going to talk about that.
Yeah.
And he came back to see me for follow-up on Friday afternoon. And I don't remember my patients from day to day. So I'm like, hey, how are you doing? What can I do for you? And then I look, I'm like, oh, you're here for a follow-up. I'm like, dude, what happened to your lid? It was almost completely 100% gone. And he had gone to a different doctor who put him on Doxy and put him on Maxitrol and put him on, I mean, so it's something to really, really concentrate on now.
And it's, again, it's for all of us. If we would kind of go to this, think back when we looked at, you know, Baudouin's circle earlier today.
Yeah.
It's root cause. That's really what we want to, and we're getting better and better at addressing root causes. So whenever we can, that's what we should focus on. And ocular rosacea, I mean, I think we've kind of really hit that. I tried to give you guys like the most like obvious ones because I'm a big fan of shock and awe. Get a really slam dunk easy example first, because then you can get the subtleties for this. This one is tough because I give entire lectures on this. Do you actually know what the National Rosacea Society Expert Committee's recommendation for considering rosacea is?
Nerd. No, I'm sorry.
Oh, Martin, I have a rollicking social life. I spend PubMed on my Friday evenings are PubMed.
No, what is it?
It's actually, I won't even go. It is literally every single dry eye thing: itching, burning, foreign body sensation, redness, anything that can be an ocular surface disease thing. They're like, you should consider ocular rosacea. So I like to make things simple for this. If you have this telangiectasia and you get some form of flushing, a trigger exacerbation, ocular rosacea in my mind, because those are the 2 main factors for it. Because otherwise, you're going to be spinning your wheels all the time, just trying to figure it out. So you see these kind of, I say it's almost like a candy cane. And then they report or say like, oh, I have a glass of wine, and the next day my eyes are just trashed or red. You're looking at ocular rosacea. Again, this is something that's super underdiagnosed. Again, I think being in a desert environment makes it easier for us because the sun just lights it up.
I think the other thing too is that, again, it's like when you're talking to patients and they can see, they tangibly know what you're talking about. It's just, I think it resonates a lot better from a treatment perspective because they're looking to kind of make it different. Yeah. And rosacea is just, to me, it's like, again, I don't know, maybe I'm just seeing more of it because I'm looking for it so much more than I ever did before because I feel you can manage it better.
Yeah.
I mean, and I'm not talking ivermectin cream, but that's a treatment.
Yeah, so. It's a lot of these things, again, it's just amazing once you start looking for them, you're going to start seeing them. So then the impact of this here, I mean, we've already kind of talked about this. It's going to disrupt the ocular surface itself in so many ways. You're going to get the cosmetic concern, which I know ocular rosacea patients, I always mentioned that the redness, even if they're miserable, that honestly is normally their biggest thing. They're like, my eyes are always so red. So we kind of know what the downstream thing is. So now we'll kind of talk about the treatments, which we've went around for this. And yeah, so you had mentioned ivermectin, things like that. But really, when we come to Demodex, I'm starting at Xdemvy. I know you are too at this point, right?
Because there isn't anything else.
No.
I mean, it's the only FDA-approved medication for the eradication. Now, I'm going to throw something at you that somebody came to me with the other day. But, is that we're getting rid of the mites. And he said to me that he read this whole paper about the fact that there's a reason why we have parasites that live in our body, that we coexist. They serve a purpose, to your point. You said that earlier in the talk. Yeah. And so his concern is that by removing these, are we putting ourselves in jeopardy? And I looked at him, I said, we're not removing these. We're lowering the load.
I'm lathering my body in Xdemvy now, actually, because I'm trying to get rid of the entire thing. So I'm working on a full body scrub, actually.
I like that idea.
Yeah,
I like that idea.
Yeah.
But it's like, this to me goes back to that same thing we always keep talking about, the dental model. And I tell patients point blank, I'm going to start you on a treatment. It's a 6-week course. It's twice a day. It's going to remove the biggest load of your mites that are in your follicles, but we can't get rid of them from your body. So it's like tartar. It's like plaque that builds up on your teeth. I'm going to see you back in 6 months, or I'll see you back in a year, and we'll see if we have to do it again. But plan on this being just like a monitoring visit.
And I really like, we use it ad nauseum, the whole dental model and these analogies, but when it comes to ocular surface hygiene, I think it works so well.
Yep.
Because the way I kind of see it is almost, I feel like Xdemvy to me is kind of like when you get your fluoride treatment, like that's kind of your big thing with this. But I don't just stop at that. I'm at the point now where I've evolved in my thinking of just ocular surface hygiene for all of my dry patients. But I'm actually at the point where I think we should all be using this now. So like one thing is, for instance, like hypochlorous acid, it's very gentle. And really, I think just about anyone could benefit from it because you're still keeping microbial burden down there. You're doing some form of that because we don't wait till we get a cavity, or at least we shouldn't for that. Because I had pushback once. They're like, well, you're having all of your dry patients, even if they don't have signs of, of blepharitis, anything like that. I'm like, well, it's not going to cause any harm. And if anything, when we have water running down our eyelids as our current form of hygiene, I think we could at least do something for that. Because I mean, we wash all the rest of our body, right? But we don't scrub the lids. So why are we ignoring this area? So that's just my take on it. I really think we don't do as good of a job proactively to take care of kind of like just external ocular surface disease, like hygiene to prevent disease. That's just mine. I might be a bit extreme on that. So what do you think?
No, I don't disagree, but I don't know. I'm not a huge hypochlorous fan. It's just, it's bleach on the eye. So I almost kind of like, to me, it's one of those things you kind of go in and get some deep clean. I like the surfactants. I like the ones that basically, have a little bit of a antimicrobial, but also reduce the protein load.
Do you use any like Zocufoam, any of the ochre-based cleansers? Yeah, because I like those a lot too. What a lot of times I'll do with the hypochlorous acid is, that's an easy one because it's a nice spray. But for patients who do tend to be more sensitive, I go to like the ochre-based cleansers because those tend to be really, really good. And they work well for that. So it's just kind of each patient, which one I find for that. So, and then baby shampoo. That's the only wrong answer, quite frankly, right there, is just no baby shampoo there. In-office treatments. So this is another one though, with kind of going to the dental thing is, I see this as routine cleanings. And actually I'm getting even more on doing this now, where I really like to use some form of microblepharoexfoliation, like you said, lid margin debridement. Now, have you used Rinsada yet?
I have been around Rinsada.
Okay.
I haven't. I'm Rinsada adjacent, and some of you might say, "What's a Rinsada?" So
yeah, so it's really new, and it was when I first kind of heard of it, I'm like, okay, interesting. Right when I first started, so I'm like, I'm going to need to hear about this. So basically, all it is it's basically a lid retractor, just a J hook that goes onto a syringe. You put it underneath the lid, and it actually has channels kind of bored into it, and then it's onto a syringe. So you're basically jetting high velocity saline up under the lids into the fornices. And at first I'm like, okay, kind of nice. But then I actually talked to the guy who actually created it. He's a retinal specialist in Pittsburgh, which I'm kind of like, what's a retina guy doing with the ocular surface? And his whole thing is when he would do an injection, he would always do a betadine rinse. And for all of us who have ever done a betadine rinse on patients, they absolutely love it. And it feels great. It feels fantastic. So like, because I'll do that for like EKC. And what I would always tell him, like, you're going to hate me tonight, but you're going to love me in the morning. So he was actually finding that he's like always trying to rinse afterwards, but he's like, I'm not getting really underneath. So that was kind of the genesis of the idea. But he actually did a study and showed that there was a reduction in MMP9 after doing a rinse. And there are some other studies like that he's done, and it's been really impressive here. And basically, it's just a simple thing, really. But to me, it's kind of like a reset of your tears, because we know with ocular surface disease, you're going to have elevated inflammatory factors in the tear film. So by using this kind of high velocity rinse, you're basically stripping that tear film, and your body's going to regenerate it. So it's just a really quick way to give comfort. Patients I've done it on, they've really liked it. It's not like a long-term solution, but they're like, oh, my eyes feel good, like immediately.
Do you do that in association with any of your other in-office treatments?
So right now I'm almost exclusively doing it with the new lids.
Yeah.
Because what I'm doing is I tell them I'm basically cleaning outside in. So I'm like, first I'm going to kind of clean off the outside, and then I'm going to rinse the inside. And patients get that. They're like, oh, that makes perfect sense that you're kind of just doing this. So, and then I'll do that with like IPL and RF and everything. But right now that's kind of my go-to, is that first I'm going to, I'm going to scrub the outside, then I'm going to rinse the inside. And that one at this point, I'm kind of playing around with having patients just do that routinely, just every few months at least, or as needed, because again, I'm getting more from the fact that when you talked earlier about amniotic membranes and big guns, we're at such a point now where I feel like we're getting obsessed with saying like, oh, procedures are that next level, where I think we should be reaching for some of these things a lot sooner.
Absolutely. It kind of goes back to that whole, adherence to treatment and jumpstarting them on a treatment in the office.
Yeah.
You have the opportunity to do that. Your patients will benefit most. The only thing I'll say about the Rinsada thing, the price point of it is very reasonable, but I think it has other applications aside from just kind of like flushing out the biofilm and cleaning. Think about your patient who comes in and says, I feel like there's something in my eye, right? It's a great opportunity to say we can do something to really get it in there and irrigate and flush to make sure there's nothing in your eye. You mentioned EKC. And it's interesting because the betadine wash, if you've never done, betadine, if you've never done the povidone acid or, alcohol in the eye, then you're missing out. For somebody who has had EKC, I can tell you it is a game changer, and having the Rinsada to be able to do it really, really makes a difference.
Especially because most of these patients, you're going to peel the membranes right before. So basically what I tell them, like, okay, I just picked a scab and I'm about to pour, like basically, put some salt in the wound. So you're really going to dislike this. So yeah, getting that. So again, it has so many things, and I've used it for the patients who say they have something, they love it because they're like, oh my gosh, I like finally feel some relief from that. So simple thing, easy way, especially if you're just trying to get into doing in-office procedures. Something like the Eyelids and the Rinsada are a great way to start.
I also would comment on, we talk about it, and it was a slide that Selena had that's in your deck from earlier, and it's obstruction and inflammation. And, also that double wheel we talked about, one of the first things that causes changes to the meibomian glands is microbes, is things on the lid. It's the Demodex, it's the blepharitis, the staph or the strep, it's the meibomian glands, it causes that evaporative stress. And so I don't think we put enough thought into opening up the obstruction of these glands. Did you ever do probing?
So I'm not a huge fan of probing just because we're doing it blind. I think it can be helpful, but it's something for me, not a huge fan. But you had mentioned earlier, I'm not sure how much longer we're going to have to be too worried about that.
Yeah.
I'm really excited. So we kind of mentioned right now, there's something in the pipeline that basically is a keratolytic that will be an ointment that's able to basically break up any of that keratinization. And that's what I'm potentially looking forward to, because I do think obstruction is a big thing and I will debride. But probing for me, if you get too aggressive, I think the chances of potentially causing some damage to a really delicate structure are there. So not that it can't be helpful. I'm just looking forward to maybe the point where we don't necessarily have to worry about that so much.
Have you seen the new treatment that has come out of, I think, out of Nashville from Dr. Ryerson? Is it called?
I saw that where he's using a microcurrent.
Yeah.
I don't know any. I saw it, but I don't know the specifics of it. But
so you guys will hear about a device that's basically, it's an in-office and a home device that actually creates an electrical current within the meibomian glands, which basically obliterates the biofilm. And outside of the eye, in kind of in vitro, you can see it kind of just explode the biofilm. It's really dramatic. And the guy who brought BlephX to the market, who's also an ophthalmologist, he has developed this device that creates that current, and he feels that it significantly improves the meibomian gland. So it'll be interesting to see.
Yeah, I know about it. Again, it's one of those things. Once we saw it acts in the wild, is what I always say will be interesting. So yeah, but it is an interesting thought for that.
Yeah.
So some of the main things we know here. The big thing I want to actually talk about here is just two things. Atopic lids. So those lids that are flaky and dry. I'm a really big fan of using tacrolimus ointment. That was actually something I picked up in my residency, because you don't really want to be using a steroid ointment long term, because that can thin the skin, cause discoloration. Where that for me was a game changer, because
it's inexpensive too. Isn't it?
It's you can literally get it. Always use GoodRx, because you can get it for like max $60 for like a big tube.
A big tube.
That's gonna last them forever. So if you want a pearl for that. The other one that's interesting for me now, I don't know if I had any more for that, is Ectoin. So have you heard of like Allegro Optasis drop for that? Yeah. So Ectoin is kind of interesting for that. So one of their inactive ingredients is called Ectoin, and it's actually a streamolite. So basically bacteria that live in hot springs, sulfur springs, things like that, use this molecule to help them survive really harsh environments, because they're highly attracted to water molecules. So when you put this into a drop and you put it onto the tear film, it actually pulls the water molecules in really close, and it creates a water shield. That's what it's called in the literature. I'm not even joking. It's called a water shield. I'm like, well, that's kind of cool. Didn't think it would do that. So basically, if you have like pollen or an allergen that hits that surface, it's going to have a harder time actually reaching the surface. So this is just kind of a nice thing that you can add, especially I've been using it for a lot of breakthrough allergies, patients who are using pad a day but getting itching later in the day. It's kind of a multiple mechanism thing.
Good. I like it.
Do you use Doxy much?
Doxy, you know, what's funny is that I used to use azicite. So I was using, you know,
Yeah, the topical, yeah, when you could actually get it.
Right, when I could, and I was using it a lot, and I was also another naysayer because it's like, oh, come on, really?
Yeah.
But I've started using it back up again, and I think it really, really has a benefit. I mean, in low concentrations, it creates that anti-inflammatory effect. It kind of helps with the bacterial load on there. So for my patients who have like a consistent sense of just, you know, underlying inflammation, they're already on immunomodulators, I actually will add azicite in there.
I'm actually right there with you. It's so funny because there's certain things that come full circle for me. And I think this gets poo-pooed so much now just because it's like, oh, it's old. And things have a place. And azicite, actually, again, that was a residency thing for me. One of my attendings, he used it all the time and it works really well. So for the people who are kind of wondering with that, the way it's typically dosed is you just put a drop of it in every single night for about 2 weeks. And then you can do every other night for maintenance for that. And it works really well, especially for patients who can't take orals. But doxycycline, a lot of people were like, well, antimicrobial effect. If you're at 40 milligrams or less, you will retain anti-inflammatory properties without having that antimicrobial side of things. So there's definitely a place for it. So I'm just like you, Mark, where there's times I've kind of gone away, but I always will still consider it because I think it definitely helps.
I used to, for the longest time, I was doing doxycycline hyclate, which comes in like a tablet.
Yeah.
And I was prescribing 100 milligrams twice a day to patients. So they get basically 4 tablets a day for a month. But then I was telling them to cut it in half or cut it into a quarter. And that thing was lasting for 6 months. And I was like, the hero. But the problem was then we couldn't get doxycycline for the longest time. So I started using azithromycin, using the Duracide, and I was finding it just, you know, the combination, they were doing great. But there was a study in the American Journal of Ophthalmology, gosh, British Journal of Ophthalmology, God, it had to be about 5 or 10 years ago, that a single dose of a Z-Pak is comparable to 30 days worth of doxycycline.
I actually had a patient who was a pharmacist who that's what he liked to do. The only thing I have with my slight wariness of that is you're staying at that antimicrobial threshold.
Yeah.
That was because I'm like, I love the idea in principle, but it's because you're still actually doing that. That was my only concern for that, because it can work. And I actually, you know, azithromycin is a little bit gentler compared to doxy, but that would be my only concern because people have asked me like, well, why don't you use that all the time? And that's the only reason for that, because I'm trying to stay away from keeping the superbugs at bay, at least in my lifetime, the best that I can.
Good luck. Good luck.
And then we had talked already again a lot about surface exposure, so make sure you're looking for it. The sleep tight kind of eye presses are good. I'm a big fan of the eye seals. Do you ever use those?
I've used them, yeah.
Yeah, basically they're like a soft silicone. They make a kind of a nice seal around the eyes. Patients can even sweat underneath it a little bit. They're basically like a nice little terrarium for their eyes under there. The biggest issue is if they can keep them on throughout the night. I have so many patients who are like, you know, they're great, but when I wake up, they're across the room. They're also very sexy looking, just so you know too.
Yeah.
So yeah, that was basically what we have for this. So thank you guys. And if we have any questions, we'll answer them for you.